Hello and welcome to the Auditing Antics podcast. So today it's going to be me. Next week as well, Michelle's feeling under the weather right now. So, like we talk about in a lot of our episodes, it's important to take a break and make sure that she has some downtime to work through and feel better, get some more energy. Now, today we're going to be focusing on telehealth services. And, I've done a lot of presentations so far in 2026 related to telehealth. And I did also partner with telehealth.org. If you saw some of my advertisements that I was putting out there, the marketing for that event. And there will be more to come in the future with that organization as well, which is great. But I'm finding that even with some more clarification around, what permanent telehealth looks like here and now, and also what the extensions look like through 2027, there's still a lot of questions and still a lot of misunderstanding. And one of the things that I find, and this can be very common, it can be problematic when we have situations where people understood what the changes were at the beginning of the PHE, and then they never looked again to see, okay, how did this change? How did the payers permanently adopt these different concepts? So it's left us in this place where people still are very confused and wanting to make decisions on reimbursement only, not realizing that, hey, maybe your workflow needs to change or some things need to look a little different. So, what I have here for us today is some questions that I've been getting recently, and just a quick reminder. So, as a part of the membership that I have, there is a component to that, and this is the largest part that most people appreciate about the membership, where you can submit the questions that you have that are related to compliance, medical coding, and billing. And those come directly to me personally, and I answer those within 24 business hours. So, what we're going to talk about today is a lot of questions I'm getting from my members and my clients. But remember that I do have that membership available, and I've been keeping it up on the screen now for a little while. But if you go to stephanieallardconsulting.com/membership, you can sign up for the membership with the discount code of Auditing Antics 26, all one word. And that will actually save you 26% on the membership option that you sign up for. There's options that are monthly and also annually. So feel free to take a look if that's something where you really feel you need some of that extra compliance support throughout the year. All right. So the first question that I have here is, how do you bill for an encounter when a physician issues a prescription for an acute infection based on a phone call that the nurse had with the patient? So hopefully, as I'm reading through that, you're starting to notice the fact that they're saying the nurse had that phone call with the patient. So this particular question and scenario was problematic for a couple of reasons. As I just said, a nurse is not going to be able to provide something, even if it's communication. The nurse can't be the one communicating with the patient and then that provider bill for that service as if it is telehealth. So, if we had a situation where the provider was personally involved, in this case, it was a physician who wanted to bill for a conversation the nurse was having with the patient. But if that physician is a part of that encounter, we still have to follow all of the requirements related to the basics of telehealth. So the patient has to be aware that them communicating is consenting to a telehealth encounter that they can then be billed for. And then we have to make sure, in the same way that a nurse cannot render a visit in the office, they also cannot do that through telehealth. And, that part may sound funny, but even this morning, I was talking with a good friend and colleague of mine in the industry, and he's having issues with a practice using a nurse for something that is a service being rendered that only a physician NP or PA can perform and bill for. So we have to remember that E&M services are strictly to those types of professionals. We have physicians, nurse practitioners, and physician assistants. We don't have people outside of that who can provide an E&M service just because we're now discussing this from a telehealth perspective. So that was problem number one, where this is not going to be a billable encounter. Number two, the second part to this is the fact that we have a situation where they're continually talking about a phone call. And remember, we have to have a HIPAA compliant platform that is driving this communication between the patient and the provider that they're seeing. So I'll get asked questions about this sometimes because people misunderstand the audio only component to mean that a physician can pick up the phone or their cell phone and just call a patient and have a whole conversation and treat the patient through that phone call. And the answer is no. We still have to make sure that we have that HIPAA compliant connection that is taking place. So if they're just most commonly picking up their cell phone calling the patient, that's going to be a problem as well because we don't have HIPAA compliance, which now means that that also is not a billable encounter. So for both of those reasons, that question is going to result in a visit. Well, not even really a visit because the patient was communicating, but a scenario that is not billable due to patient communication with a nurse and without a HIPAA compliant platform. The next question we have here is, why is a telehealth statement required for the encounter when the note type in our EMR system states telehealth progress note? So we have to remember that, first of all, it depends on how the system is structured. So you could have a situation where the note template is saying telehealth, or you could have a situation where the appointment type is saying telehealth, but that doesn't mean that that's going to translate and then be documented automatically for you in that progress note, which ultimately is what's going to be printed and sent out to the payer. So this happens quite a bit when I am auditing in Epic, for example. A lot of times the visit type or the appointment type is going to say virtual or telehealth, however that's been built out for that particular organization. But then when I'm looking in the note, everything in the note is not stating anything related to telehealth. And because we have such an overuse of things like copy and paste, or overutilized or pre-filled templates that are not leaving enough empty for the provider to fill in for that encounter. I'm also seeing a lot of times where, yes, the appointment type may say telehealth, but then the HPI, the first sentence of the HPI, is stating that the patient presented on that day to the clinic for follow-up, and it'll show different conditions. So that in itself is going to create contradictions, because the other thing we have to be careful of is if a provider has a certain template type. So let's say the progress note is tied to telehealth. That could also be driving the way that the system is going to bill out a place of service or a modifier, things like that. So we have to make sure, number one, we understand how the system works. Now, from there, from a documentation standpoint, the reason that that does not help, it does not matter if it says that it's a telehealth progress note, is because we still have the other components that have to be identified in the note, such as patient consent, which, yes, you can obtain that verbally, but it still has to be documented. So patient consent, the type of visit, whether that was audio only or interactive with video used, because remember, the word telehealth, virtual, telemedicine, whatever type of way you want to refer to that, does not inherently mean to every payer across the board that video was used. So that has to be designated. We need to know where the patient is located. Remember, our place of service is O2 or 10. So that's going to drive whether the patient's in their home or away from their home. And then we have the designation of typically where the provider is located too. We need to be validating that and making sure that they're in the proper state where the patient's located, where they have licensing, things like that. And then keep in mind that one of the things I've personally been seeing over the past year is that some of the states also want our practitioners to document the telehealth platform that they're using inside their progress note. So if that's the case, it's a good idea to put that right into the telehealth statement. So it's not enough to just bill, the proper place of service, modifiers, CPT codes. If you don't have that backed up in documentation, then that's going to be a problem, because you're not going to be able to prove, just from that surface level. Remember, on that first review, that yes, that's telehealth. Now, with that being said, sometimes there are ways that you can defend it after the fact if you have very deficient documentation, like using a system that shows proof that the patient was seen with call logs, video logs, things like that. But that's not ideal at all. And honestly, with the point that we're at now, there's no excuse to not be up to date on telehealth. We are looking at things 6 years after the fact, when we had that explosion of this being more acceptable during the PHE. So when I see people that still from 2023, 24, 25 into 26 are getting it wrong, that question is, okay, what the heck are you doing? Your head is in the sand, and that's not going to be a defense. So make sure you are paying attention to the way that you have that statement and your documentation set up. All right, our next question: how do we bill for a telehealth encounter when a physician is on vacation and continues to treat the patient? Again, I would hope this sounds kind of silly to a lot of you that are listening here, but sadly, this is still a situation that's happening. So, my first concern is, where is that provider's vacation taking place? Because most do not just stay in the area. A lot of them will go out of state, or if you think about it, a lot of especially our physicians, are from other countries. And that matters, because if they're going to see their family, they're not just going to take this long trip somewhere to stay for 5 days, right? A lot of times they're staying multiple weeks, or a minimum of a month, more than a month. So all of this matters, because when we look at the location of the provider, they have to be licensed where they are located and where the patient is located. So if my provider that I'm seeing is outside of Tennessee on vacation, let's say that they're out in Nevada, if they're not licensed in Nevada, but I'm still physically in Tennessee, that's still not a legal telehealth encounter, because they are not licensed where they are located. And there's been a lot of confusion where people thought it's just based on patient location, just based on where the state the patient has insurance through. I've heard that before as well, which is crazy. But you've got to have licensing in both of those areas. Now, taking it a step further, the other reason this is problematic is because all services that are rendered that are going to be billed to CMS and to the payers have to be performed within the US borders. And that becomes a problem, again, if you have your physician who's overseas somewhere on vacation or whatever it may be. Even if it's a work trip, it's not going to matter, because they're not within the US borders. So now that's not even a service outside of practicing without a medical license in that area. We still now have services rendered outside of the US borders, which cannot be billed to the payers. And that's also why, when we look at different services, like remote patient monitoring, that's why it's such a problem if people outsource to a company in India, for example, and the majority of the work that's being done throughout the time period, the 30-day time period, is being rendered by somebody in India. They're not within US borders, they're not on US soil, so that's not a reportable service. So we can look back to the basic concepts that a lot of people tend to forget when we're looking at, okay, is this workflow appropriate? Am I still rendering a service that can be billed for? And those different types of nuances there. So we have to know where the provider is. And, a lot of times too, when I get asked this question, The providers in the room, the physicians in the room will kind of look at each other because they knew they were wanting to do that because they were leaving the state and whatever else. Sometimes I'll also be asked that question, and we're actually going to talk in the next one here about virtual supervision, but I'm starting to get questions about that now as well because physicians are looking at that as a way to still get credit for work RVUs towards their payment structure or bonus structure when they're actually gone and not even in the States because they're on vacation. So provider and patient location matters. You have to have licensing in both places or else that visit should not be moving forward, and it definitely cannot be billed for. All right. Next question is direct virtual supervision allowed as a part of the telehealth changes for 2026? So, this, I get asked about it in relation to telehealth. It's not necessarily something I would say that is a telehealth service per se, but it is something that CMS has permanently adopted where they're stating that direct supervision is now allowed. And the way that that looks is if that physician is still wanting to pay or still wanting to bill for an encounter, they need to have the ability to be physically on a platform that is HIPAA compliant and available by video in the event that something adverse happens during that particular patient encounter. And along with that, we also have to look at situations with teaching physicians because there are some rules now related to direct supervision of a resident, for example, but that would require that physician to physically be on the telehealth encounter with both the patient and the resident at the same time for that direct virtual supervision. So, why does this matter? If we think about what direct supervision is, remember that is when a physician is able to bill for a service like Incident 2 if they are physically located inside of that particular office and practice. Remember, it has to be space that is continuous. It cannot be situations where there's a different floor involved between the physician and the patient. It can't be something where they're having to run across the road to another building on the hospital campus, which, that could potentially go into split shared. We won't go there. But when we're thinking about direct supervision, the reason this looks so appealing to everyone right now is because they say, okay, great, I no longer have to be physically in the office anymore, and I can still count that as Incident 2, for example. So, my concern is that our physicians are going to be looking to do this out of convenience. So, when I'm talking about it, I always joke and say, okay, this is not your new excuse for every Friday to be your golf day now. We have to make sure that they are there ready. I suggest to my clients that that system has to be on and uploaded and ready to go in the event that there's a problem. Because how many times do we go to open our laptop, for example, and then it says, oh, hold on, you restarted it last night, but we've got to do an update before we'll turn it back on for you. Or maybe the platform itself, the telehealth platform, needs to go through an update. So the whole concept is that that provider is immediately available. And when we think about the physical location, when I was talking about the continuous site, not different floors, not a different building, not, a minimal space between buildings. Those same types of arguments are going to be made when we're having to look at and defend direct virtual supervision. So we have to make sure it's set up and ready to go and making sure that, everybody fully understands what those requirements are. Now, lastly, similar to the question before, provider location matters. So if that physician is over the border on vacation in another state, that doesn't count as direct virtual supervision because you're not licensed. Well, if you don't have a license, it's not considered direct virtual supervision because you're not physically in a state where you are licensed. So those that are looking to use this to go on vacation, things like that, that usually will shut down that particular conversation right there. All right, how do I defend medical necessity when the visit could have been done in person? So this is a really good question, and this question makes me think about it a little differently because when I'm looking at telehealth services and really validating the reason, I always think to myself, okay, medical necessity is here because they're doing this instead of the patient presenting to the practice. So during the PHE, for example, we had a lot of issues where physicians, we think about what happened with patients no longer suddenly coming into the office. We definitely had time periods where it was very greatly affecting revenue, things like that, patients canceling. And what started to happen is we would have a physician maybe call the patient and say, "How are you doing? I know you just had surgery." And then they're trying to bill a level 4 E&M service for that particular visit. And we're like, okay, why is this happening? You wouldn't have done that prior to the PHE. So why are you just cold calling patients now and thinking that that's a billable service? So when I think about medical necessity, I always think about the situation would be something that would require the patient to come into the office. And where we see a lot of issues with this still is something like a patient who had diagnostic testing done. And again, now that we have telehealth, a physician may think, okay, if I call the patient back instead of my nurse, that means that I can bill for that visit. And then they call them and say, hey, your recent CT scan looks great. There's no abnormal findings. You can come back and see me again at your annual preventative visit, something like that. So that's problematic because we don't have medical necessity to bill an E&M just because you're telling the patient that their lab results were normal. The patient has a right to know what the outcome of their result of testing is, regardless of the way in which you are going to have that workflow occur in your practice. So the flip side of that is going to be if there is abnormal findings, which then prompts new management decisions. It's actually the new management decision that supports a billable E&M service, because think about that. That would be a time where typically if we didn't have telehealth, if the results were normal, we'd be hearing from the nurse or an MA telling us, hey, it's normal. No need to follow up right now. We'll see you again in the future. If it's abnormal, you'd be getting that phone call and they'd be telling you, okay, we've got to set up an appointment within a certain time frame to discuss next steps. Then the patient would need to go into the practice because the new management is the driving medical necessity for that encounter. So that question was worded kind of in the opposite way, but think about it in those terms. If you wouldn't have the patient come into the office, you better be questioning the medical necessity on that. All right, how do I appeal denials for services that are not appropriate for telehealth, or meaning that the payer is telling the practice that the service is not appropriate for telehealth? So this can come up quite a bit, and I will tell you, it seems like the answer to this would be very straightforward in researching your payer policy and looking at that to determine if the service is something that they will cover through telehealth. Where this gets tricky is when you have different managed plans in place. So you could have a Medicare Advantage plan, you could have a Medicaid Advantage plan, a replacement plan. And at that time, we've got to be thinking not only of CMS for Medicare patients, for example, or just the Advantage plan or replacement plan for Medicaid, but we also have to be looking at other sources that could be involved. And I just had this happen this week where the patient had a Medicaid plan through a commercial payer, and I'm having to go in and look at the commercial payer plans, looking to see if it states, whether it's Medicare Advantage, an exchange plan, commercial plan, or state plan. But then also remember that the states themselves have a Department of Health and Human Services, and they often will put out their own policies as well. So not only do you need to go in and look at, let's say for Tennessee here, there's 10 Care under Blue Cross Blue Shield. So not only do I have to look under Blue Cross Blue Shield for Tennessee, but I would also need to be going in and looking at Tennessee policies for the state to see if they have different limitations as well. Now, in addition to that, when you do find the policies, you have to make sure you're looking at the type of practitioner who's allowed to render that service. So sometimes they will say, okay, these different types of licensed practitioners are allowed to render services through telehealth, and then they may dwindle it down even more from there, depending on the type of service that they are going to allow to be rendered through telehealth platforms. So there's not one answer across the board for this, but you do have to do your research. And this is really something that's better to look at before you start billing everything. Obviously we're in the thick of it right now. So if you're coming across a situation like this that's impacting revenue and the office, maybe pause and think about, okay, who are our top 5 payers? Do we fully understand what their plan is, and are we following that correctly? Because we're not going to be able to do one thing across the board for CPT codes, practitioner, modifiers, place of service. All of those things can differ when we put the different insurance companies into the mix. All right, so that is the last question that we have for today. I'm hoping this clarified a little bit of telehealth. I know this has really been a struggle. Like I was saying in the beginning, feel free to check out that membership. It's something that really is helping a lot of people, not only to ask questions before something's billed, but also if you have denials and you're trying to tackle the back end as well. We hope that Michelle will start feeling better. We'll see her back in a couple of weeks. I'm going to be on vacation next week. I'm very excited about that. I am going to pre-record the podcast episode for next week, so we have that continue to move forward. But I hope that everybody's doing well. Remember to take some downtime yourself. Hopefully last week's episode on stress and thinking about how that affects us at work and our personal lives really resonates with some of you, and you're able to implement some changes there as needed. So I hope you have the rest of your week that is stress-free or at least minimized, and I will see you back after vacation.